So what I'm hopeful to sort of do as a deep dive, because I think we've got a great group on the call, especially from a good sort of balance between physicians and rehabilitation professionals, is I'm gonna maybe, and Brad, maybe you can kind of work with me on this one as well, just when we think about that patient journey, and maybe even from whether it's a patient coming from the expertise of an orthopedic surgeon or physiatrist or sports physician. What does that typical journey look like, right? And I think it would be great for us to have sort of that understanding as a group of, okay, what does that patient look like? And Brad, maybe we'll partner on this one here if you're okay with it. Well, let's think about that, typical day surgery you would do. Even though I don't specialize in foot and ankle like you do, but let's use a typical case. What's the typical day surgery procedure that you're doing on a regular basis?
Well, traumatically, you'd think of things like, ankles and wrists and stuff like that. So, but electively, we could say total ankle replacement or an ankle fusion or something like that.
Yeah. And with that, and let's sort of look at that case as a group. So let's do total ankle. Yeah. At any days in hospital right now?
Right now, if you're in Toronto, Tim Daniels is doing mostly home because he's got some popliteal nerve blocks. Our hospital is not set up right now for indwelling popliteal nerve blocks, so I do need to admit patients for at least a day.
Okay, interesting. So
for pain management.
Right, interesting. So again, if I think about this as a physio, right, there's actually a potentially a difference there between someone who's coming home post popliteal block versus a GA, and how quickly I may see them. Even though this, the potential surgery itself, other than obviously the surgeon may have a slightly different approach, but at the end of the day, the joint has been replaced.
Right.
So let's say, one day in hospital, no complications. How do they get discharged from the hospital?
They get discharged from the hospital after their physiotherapy assessment to make sure that they're safe, as they say, to go home and someone just put some and to make sure that they know how to use crutches or a walker or be non-weight bearing, and then they'll go for that 2 weeks in a cast, and then air cast boot at 2 weeks, start range of motion but non-weight bearing for 6 weeks.
And then do they get any home care in there too, Brett?
They do not necessarily get home care.
Okay.
And they don't get any sort of in-home physio for the first 6 weeks. They don't get any real home care unless we apply for it, which would then make their length of stay longer, of course, if they needed it. If they need it, they'll get it, but classically, no. So nothing rehabilitation wise until at least 6 weeks, which, and from a total ankle point of view, the funding, as we talked about before, with respect to hips and knees is different. They're not getting prehab. They're not getting, here's your crutch, that sort of thing.
Yeah. Like there's no bundle of care, right?
On my part, but.
Well, and the thing too is, and it's still at the end of the day, it's what we have access to at this point. And I think, from that perspective too, I'm actually curious in the chat. I want to see everybody actually participate. How many total ankles have you treated, let's say, in the last 2 years? Just throw it in the chat. I can tell you I've seen 2. And that's all that I've seen. Right. So it's, so let's get a general sense. And so on that scenario though, Brad, what you typically are seeing, when do you make that referral over to PT, chiro, getting them into the rehab clinic? Is it 6 weeks?
Usually goes in at around 6 weeks. Then they'll be seen, a couple of weeks after that. And then I will get some calls sometimes, what can we expect? What do we really want to do, etc. But not a lot, actually, surprisingly. And that's about,
and I think that's sort of the interesting piece, right? Like, but let's kind of put this into a perspective. Let's say if all that was done sort of in, let's say the hospital, like let's say it was all done in fracture clinic, like physios were treating beside you. What do you think the amount of communication would be though at that 6 week mark when you did say, hey, Darryl, this gentleman is clear, this this particular lady, she's ready to go to PT. What do you think the amount of discussion we would have at that point and expectations could be if we were side by side?
I suspect it'd be every visit, to be honest.
Yeah.
And it would be a welcome discussion. It would be
Mhm.
me coming in saying, how are you doing? That, so there's that little bit of PR, I'm interested in your treatment, which I know I am, but sometimes we don't
Mhm.
always see that aspect. And
Yeah.
B, so whether the physio or someone needed my input or not, I could still say hello to the patient and make sure that everybody's on the same page with respect to verbiage, like we've been talking about. Oh, you're doing well. Oh, you're in this part of your thing. So
Mhm.
I think it would be very high, and I would love it if if I had that
Yeah.
clinic beside me. Yeah.
Yeah. And I think too, like at that point, like that's just that it's an ideal, perfect situation, right? But you can see like what we could do. I guess the question for me would be, given some of our limitations right now, how often do you get, let's say you make that referral out at 6 weeks. When do you do your next follow-up? Would it be 12 weeks post?
Yep. 12 weeks post.
Okay. How often do you get a note back from the community, from PT, chiro?
Mm, maybe 30%, depends. That's
Yep.
a, that's a, just a guesstimate off the top of my head.
So it's low.
I think it's low. I don't, yeah, it's not, yeah, I would say it's less than 50%, to be honest. Now I do get some discharge stuff, but I
Mhm.
don't get I don't get a dialogue. I get a, here's what happened and
Right.
this is where they were when we finished kind of thing.
Yeah. And I think the one thing too, and maybe this even goes down to, post-op protocols and things like that as well, right? Like, so if we were to say, what are the expectations that you have, Brad, for a 12-week follow-up with the total ankle? What do you expect to see to know that patient is on track for positive, good recovery?
Oh, I want to see them weight bearing without their boot. I'd like to see 10 degrees of dorsiflexion minimum as a range. And no one leaves the operating table unless they've got a minimum 10 to 15 degrees of dorsiflexion, whether I have to add an Achilles lengthening or a gastroc recession. And so that'd be about, and pain much better.
Mhm.
Now, total ankles and ankle fusions, they're not as good as total hips. No one's ever 100% pain free, but I would like to see that they would have the operation again, if you know what I mean.
Right, right. I always bug my buddy Dale Williams because Dale says none of his total hips limp. What do you think of that, Brad?
What's that? He
He
what?
he says none of his total hips limp. I'm putting this one on recording just because I bug him all the time. I'm like, I see a limp.
That's because he does the posterior approach, I think now, doesn't he?
I think so.
No more hardened.
Yeah. So this is the interesting thing that I'm trying to get across in this is that, we've got an individual here as a physician and an expert that says, I'd love to actually have some more dialogue specifically, like, do people need to know where guidance is and what we should see? But I guess the question I have for the group is, let's say, the protocol outlines quite well, those particular, 12-week, so 3-month outcomes that we're looking for to get a sense of whether that patient is on par for good recovery. What happens if we don't see that? What do we do? So I'm going to kind of pose it to the group right now. If let's think of it as a rehab professional. So we've received this particular patient and they're not meeting those guidelines or that, each of those milestones that Dr. Petrosaurus identified. What do we do? Throw it in the chat. What would you do? And as people are sort of typing into their, Brad, I'm actually curious too, is when you think about some of these patients who have, maybe persistent pain, they're centrally sensitized, how do you tend to collaborate with maybe primary care to support that? If I was to raise a flag, this patient, seems to have quite a bit going on, or we're having a difficult time managing symptoms. Do we tend to see you guys, do we collaborate more with family physician, sports doc, physiatrist? Where do you tend to go there?
Um, well, with the ankle piece, I usually just start seeing people back uh, clearly. Like, so if someone calls me and says, look, so this guy's not doing well, then I'll see them back much sooner and then start to work through my own sort of diagnostic algorithm
Mm-hmm.
as regards pain post total ankle, say. but I'm not actually working. I don't find that I'm working. It's the rehab team would probably say, well, we're going to hold off until you get things sorted out for either pain generator. Do you know what I mean? And I may say that to the patient, but I'm not doing a lot of back and forth. Actually, I'm just sort of doing my own sort of diagnostic workup algorithm for post pain stuff.
Yeah.
Now, if I come down to some sort of diagnosis that I think is that there's nothing bad and that a lot of it is a rehab based, then I will communicate. But I don't I no I don't I probably I need to be doing more, but I don't always do that.
Yeah. And I guess if you were to think about it in an ideal world, Brad, what do you even recommend for us as rehab professionals? You're busy. It's hard to, at times people would say, well, it's hard to get a hold of the orthopedic surgeon. I have access to sports physician, physiatrist. Is that an avenue that, we should start funneling if you think about the private sector to get patients managed well?
I think so, but it depends on the procedure. So, like you've seen, there's a bunch of people who haven't really treated total ankles. And so sometimes when you get that specific, they're like, well, I don't know what the pain generator is. Just have a quick look. Now, when you have someone who's very facile with hips and knees, then that diagnostic thing will happen more fluidly in the rehab clinic, I think. So our example is a little bit specific. But if clearly someone's not progressing, I personally, I am very much in tune to, getting a quick email from somebody, and I'll give them a quick call and just say, hey, this is what I expect. This is what I don't expect. That solves problems way quicker and much better, in my opinion.
Yeah. No, I love that. And I think
everybody's busy, but a quick phone call saves everybody time.
yeah, absolutely. And I think Sherry raises a good point. And I think, Sherry, I think you're a physio, so I can see where you're coming from on this one, right? So what are some of the drivers for individual patients to have, what is sort of driving some of this pain, right? Especially with how well the pain science world has evolved over the last couple of decades. Go ahead, Brett.
But that's a great point in terms of being on the same page with the pain generator. Look, we acknowledge that you've got pain. There are reasons for you to have pain, but we feel that, together we feel that what we're doing is safe for you to progress your rehab, et cetera, et cetera. And sometimes that gets missed when you're not in that sort of really intense collaborative model, which, when I see people on the chat having all of these people with them, I envy that. To have a clinic like that would be just awesome.
Yeah. And I honestly think too, there's, the way that our world has, basically fast tracked virtual care, right? Let's see, is there opportunity to create some more collaborative models, right? And we did, I think, Abby, I think it was the first world tour. We actually did, we kind of presented a case model where we were doing some virtual consultation in collaboration with neurosurgeon and physio side by side. And I think someone had mentioned it earlier too about, can we do some more of these combined consultations, but do we really have to be physically in the same space? Because there's multiple limitations to that as well. So I'm just trying to think too, what's Dr. Cruz? Yeah. And honestly, there's a ton of issues around privacy when it comes to a lot of this work as well. Right. Yeah, and if you can get past the gatekeeper, perfect. Dr. Cruz, bang on. And I think though this is just where I don't want everybody to sort of leave this, this session and Brad, I'm sure a couple people might call you tomorrow, but the reality is that it's baby steps, right? Like it's just about how do we move one step closer, right, in the private sector, because this isn't an easy fix. It's not just Darryl could present this model and we're all going to be working collaboratively tomorrow. What is one thing that we can change in our practice Tuesday morning in our brand new consult, or the referral we receive from sports doc, from physiatrist? So just thinking about that, and I'm going to kind of skip a couple pieces here actually, because what I'm curious now, we kind of look at this, kind of creating a little bit of this patient journey of, this total ankle patient. if you think about, some of the pain generator stuff we talked about, if you think about patients who may or may not be meeting expectations along, various milestones, difficulty at times of being able to all, be on the same page in the same working environment, right? Or the same setting. But if we were to think about that, I'm actually curious, who would you like to have on your team? So thinking about your practice setting, thinking about who works in your clinic, and it doesn't have to necessarily be about, this case that we kind of drew up here with Dr. Petrosor, but who would it be? And you can think of this too as in just an internal collaboration. So again, who's in your clinic environment, multidisciplinary clinic? And a typical example of that would be, we have a patient, which is this little pond looking character up here. We got clinician A, clinician B. This thing could certainly expand into clinician C, D, and E, right? In a multidisciplinary team. Which health disciplines, which physicians are we thinking about? The model we had sort of taken as an approach to just this, this example for this evening was just, this, I couldn't find a picture of Dr. Petrosor right off the bat, but I could have replaced this one. And myself hypothetically saying PT, orthopedic surgeon, and patient. And we certainly simplified that from an IPC perspective. But I'm just curious, let's get everybody to fill up the chat. Who would you put on your team? And I think as you guys are thinking about that, just to sort of put on recording, I think we have identified some really, important barriers to this though, which is time and being able to communicate with, with individuals in that timely manner. We've identified some privacy issues, right? So privacy legislation is very important to make sure we're dealing with secure sites and pathways, and funding being a barrier. Sometimes positive from a funding perspective, but on the other side of that, quite difficult.
Darryl, would it be all right with you if we ask people to come on video?
Yeah, absolutely.
Chime in if you want, just unmute yourselves and just chime in.
Let's,
and
I'm going to stop the share too, Brad. How's that?
Some comments.
Yeah, so let's just kind of because the screen's down. So let's say who is it that you think is not quite on your team yet? Dr. Quarterly, please share.
Well, kinesiologist for sure. So I guess I'm thinking about this about years ago when I was a physio. I was at the Rusk Institute. We had 75 physios on staff. And I'm thinking that one of the things that happened, it was we rounded on everybody, but you could do that in a Zoom meeting. You could actually, as long as you were very, you were clear and you were goal-oriented and you were tight. And I think it's a way of, I don't know, I think Zoom might be a way of handling it. I've listened to some of the webinars from the VA hospital where they talk about limits of funding and how they actually, long before all of the pandemic, they would get people to collaborate where there were barriers to patients getting to the clinic, and they would do it all on a similar thing. They would do it on something like Zoom. But the point being is that everybody was very clear what the goals were, and they had a very tight meeting, but the patient was included as well.
Yeah, that's interesting too. I guess the question is would we have to round on everybody? Right? Or would it be, there's outlier cases, right? Where we get into some of that complexity, which definitely requires that interprofessional mindset to figure out how to manage that. But I agree with you, Dr. Quarterly, like Zoom became an avenue. Now, the question is just to Dr. Cruz's point, make sure it's the right Zoom that's actually privacy protected. But I think it's something that we certainly could explore without a doubt.
The other thing, sorry, there's just one thing that I think the thing that bothers me is that people don't have a great enough expectation of where to go. Like they don't, like there seems to be a limit in what people do with rehab. And it's always puzzled me that people don't expect more out of the process. Anyway, just saying.
Interesting. No, that's great. Thanks for sharing. Dr. Cruz, you're unmuted, so.
Actually, Dr. Corley, do you mean the patient doesn't expect enough or the practitioners don't, or both?
I don't think the practitioners expect enough.
I agree with you.
I think they are so limited in what they think is possible. Yeah.
You know, I think back to, I've been doing this a very long time, and I had the very wonderful opportunity of mentoring or being mentored by one of the sport orthos in Toronto, who was at the old orthopedic and arthritis hospital, now part of Sunnybrook, Holland Sunnybrook. And they had a fabulous system where there would be a bunch of the surgeons in clinic, and there'd be physio in clinic with them. And people were coming from all over Ontario for this. And you know, one occasion, the sport ortho that I was shadowing and working with had a guy from Sudbury who actually needed probably a total knee. He didn't need a scope. So we walked the patient down the hall to the arthroplasty specialist, who was one of the well-known, well-renowned older orthopedic surgeons in Canada, and said, "Can you please see this guy? He came all the way from Sudbury." And his colleague said, "Of course I can." You know, so that was a different kind of environment. And then the other environment that I worked in, well, two other environments, they were both hospital-based though. So our therapy staff, one was at Women's College Hospital when we actually had an academic sports medicine clinic there. And we had special programs for pregnant women or postpartum women. We were connected with the cardiac rehab department for offering care for women who might have heart disease or risk factors for heart disease. And the other place was the sports medicine clinic at North York General Hospital. And Dr. Bob Brock ran that, and he always had physio, and he always had a ton of learners. And it was always very patient-centered. Now that was very much sort of the staff of each of those clinics that we, Women's College is very female patient-centered and always has been by history. But the gender and the sex of the patient actually didn't matter. And at North York, Dr. Brock was a fabulous teacher. You take that out to the community though, and what we have now in the challenge with collaborative care is funding. So who's going to pay for that second consultation? Who's going to pay the staff for the team meeting? Well, sometimes it is the owners of the clinic. Sometimes it's, okay, let's do case review. Who has an interesting case? We're having supper. Let's all get together, and we encourage someone we know may be struggling with a case to present their case, but in front of their colleagues, the other docs, well, other colleagues of all disciplines, basically. But at the end of the day, the funding is the issue. And as the clinic owner, I'm one of them, we're just paying to bring people together to have that communication. And so depending on your model in the community, that may or may not work. And it really depends on the kind of culture you want, and also whether or not your physios are not working for you full time and maybe have to go someplace else. So they can't stay to do that because their afternoon is at another clinic. So the funding models in salaried positions, hospital-based family health teams, I think, you know, some of this old team stuff has to come back, and it's been lost certainly in, I think, in musculoskeletal care in hospitals.
100%. I mean, look at how many physio clinics are in hospitals now. In Hamilton.
Yes. Yeah. Yeah, we have very limited at some of our local hospitals, and, you know, it's limited to a few visits after you've had your orthopedic surgery.
For sure. Sherry, any thoughts as a PT?
So I work in an advanced practice role in the hip and knee arthritis program at a hospital in Toronto. And I would say that I have great communication with the orthopedic surgeons that I work with day in and day out. So it's the walking down the hall, you know, touching base, everyone in the same room at the same time with the patient, but that doesn't happen very often, right? I do a 6-week post-op visit, and the rest of the time I get pulled in only if there's an issue. And communication with the clinicians in the community is a much greater challenge.
Yeah, and that was sort of an interesting scenario that I presented not too long ago as well, is to say, you know, if you know that getting access to, you know, let's say the orthopedic surgeon, but as someone like yourself who works very closely with them, kind of really knows what those expectations should look like, what they could be, or what they should be, and then just something doesn't seem right, and this is something that needs to be prioritized to get in to see the doctor sooner. there's very little communication from PT to PT, from PT to chiro, from chiro to PT, right? And we're starting to see this expansion into the community, especially in the rapid access clinic for spine, where you see PTs and chiros working closer together. We're still not seeing that good communication that happens. When I could comment in my practice a little bit, is that I do see people will reach out to me these days. For physios, will say, I have a hip patient that, may or may not need a scope, and I'd like to get your opinion on, has that patient been worked up? But I'd say, this is just happening now, a decade of me working with scope patients, right? And working with the orthopedic surgeons closely. But it is a step for me in the right direction. But also for me being in that role, I would have no issues reaching out to a colleague for their consultation and their input. And we've even seen some cases, and to Dr. Cruz's point, is most of it does fall upon the clinic owner at times, or, administratively at the hospital. At some point, we're going to be making decisions to say, well, is this program going to continue to be funded? Depends on what the LIN decides as well. Like, it's just super complex. But at the end of the day, we actually have seen some people even paying for that consultation, that advice, as well, to move the patient in the right direction. But sometimes it also comes down in many cases to whether patients could afford that consultation as well in the private sector, right? So again, definitely, interesting times for sure. And no easy solution to this. But again, I think if there's that focus and that, the desire to move back to a team-based model of care, as Dr. Cruz has said, there's ways to do it. There's certainly risk associated with it, and majority of it will come down to funding. But I do think there's some creative ways that we've learned from the pandemic. We may not have the answers yet, but I just think the creativity around innovation and what practice models could look like certainly does open the door for some possibility. But I don't know what the timeline that would be. But I think if we start and we think about small wins and baby steps, I think we have an opportunity to move a little bit closer to a collaborative practice model in the private settings. So on that note, Dr. Petrister, I'll pass it back to you. Oh, sorry, David, did you have something there?
Oh, you're asking me?
I didn't know. I just saw you went unmuted there, so I didn't want to leave you.
Well, I would say that, the key to it is considering, patient-centered care, because, if the focus is not on the patient, then it's really easy to stay in a siloed approach to things. But when the patient's best interests are forefront, then it's easier to think about what else does this patient need.
Mm-hmm.
Yeah.
Excellent. And again, that very bottom, key point from even just the work in 2010, right? It's all about the patient, right? And how do we, continue to keep them at the center of attention? So Great point. Thank you. All right, Dr. Petrister, back to you.
No, I don't have anything to add except for the fact that I'm very cognizant of the time. It's just gone 9, and that was a fast hour for me anyway. So and if anyone has any final thoughts, please feel free to voice them. And if no one has any final thoughts, then I would thank Darryl for a great hour spent. I thought it was really great. And I, for one, love the collaborative experience that I see in different areas of medicine. And to your point, David, just always being focused on the patient. And I just thought the points that were brought out in terms of the consistent messaging is so key. If everybody's on the same page, it just makes it so much easier. So thanks so much for everybody's contributions and comments. Darryl, thanks again. I'll leave you with a final word if you want it.
Yeah, I'll always take a final word, Brad. No, I just want to say thanks to everybody. And I think the one thing though for us to still reflect upon is that many of us have, probably some, very specific programs that we're running in each of our clinics. Like Dr. Cruz mentioned the GLAD program. There's lots of things out there that people are doing, and they actually have, there's an opportunity to make a step in the next direction. And I just think the more that we have these types of opportunities, so again, thanks to you, Dr. Petrister, and the OE team, Abby, these are just great ideas for us to kind of get our creative juices flowing. And I think, again, we have an opportunity to step in the next direction. And again, I encourage you all to challenge the status quo and focus on that patient-centered model of care. And I think our collaborations will continue to expand. So thanks again to you guys for the invitation. I really appreciate it.
Thanks again,
Thank you,
Darryl,
Darryl.
so much.
Appreciate it.
Abby, thank you for all your work behind the scenes and in front of the scenes. And thank you to Ortho Evidence team and Mo as well for these insight events.